So in Responder, we randomized 5,000 patients who had a recurrence score of 25 or less to taxane or anthracycline-based chemotherapy followed by endocrine therapy versus endocrine therapy alone. And at the third pre-specified analysis, the findings that were observed by the Data Safety Monitoring Committee, as well as by the study sponsor, the NCI, the feeling was that we needed to report these data, with a little over 50% of the population, having reached the events that we were anticipating. And the reason that these data were presented is because we were observing a significant differential effect based upon menopausal status, right? So where the patients who were postmenopausal, which was 2/3 of the population, clearly at 5 years were not having any benefit from the addition of chemotherapy. If you look at those Kaplan-Meier curves, they fully superimpose with a hazard ratio of 0.97. This is as opposed to premenopausal women, where we saw an improvement in invasive disease-free survival of a little over 5% in patients at 5 years. And then also this early overall survival improvement with a hazard ratio of 0.46 in the patients who are premenopausal. So for postmenopausal women, as part of Responder, if the recurrence score was greater than 25, the recommendation was that patients would receive chemotherapy followed by endocrine therapy. They weren't followed as part of Responder, but there's still clinical utility in this population of checking a recurrence score, because if it's greater than that level, then as part of the study, they would have been recommended to receive chemotherapy followed by endocrine therapy, and as I said, not followed as part of the study. However, if the recurrence score was 0 to 25, at this point, we did not identify any subgroups of patients who benefited from the addition of chemotherapy in postmenopausal women.